Alicia, could you talk about, we have these three drugs now, so enzalutamide is approved in nmCRPC and mCRPC. Apalutamide is approved in nmCRPC and mCSPC, and darolutamide is approved in nmCRPC. So for the nmCRPC population, your thoughts on scanning and also, the different AE profiles of patients that might, or comorbidities, drug interactions, molecular structure. How do you come to talk to patients? Because they're not going to really know. They want to understand, well, I've got three options. How do you choose?
So great question, and really to address your question on scanning, if it's around the newer molecular imaging techniques, I use that traditionally in the biochemical recurrent hormone sensitive state to understand if there's something metastatic that I can see that I couldn't see on conventional imaging that may make pelvic irradiation as a salvage therapy less beneficial to patients if they've got recurrence after prostatectomy. But otherwise, I would say I use those pretty minimally because I don't necessarily have a way to act on them, except in the situation that Nancy mentioned. And I actually make my treatment decisions about non-metastatic CRPC actually based on conventional imaging, because that's how the studies were designed. So even if a patient has M1 disease by molecular imaging, as you mentioned, I still feel that those patients can benefit from the drugs that are actually approved in the non-metastatic CRPC setting. And the way that we see these drugs crossing and spanning the metastatic CSPC, non-metastatic CRPC, and metastatic CRPC setting, there's just benefit across the spectrum. So I feel pretty comfortable with that decision. When I'm trying to choose between those drugs that are available in the non-metastatic CRPC setting, I think about multiple things. Honestly, I first think about side effect profile. They can be a little different. And they all have their distinct side effects. Things like fatigue and hypertension that might be more common in enzalutamide, or a rash and thyroid problems, and as well as some fatigue maybe with apalutamide, and then darolutamide that may still also give a little bit of fatigue. There may be some falls actually across the board, but maybe less in darolutamide. So these are all kind of distinct. But when I think about drug-drug interactions, which are another thing that I think Nancy's mentioned, that may be a little less with darolutamide. So comorbid disease, side effect profiles, drug-drug interactions are all things that I think about. But at the end of the day, I think that we have sufficient data that it's worth treating these patients. And again, that just gets back to this benefit that we see across multiple parts of the disease spectrum. And we have new data that I think we'll talk about, where we now see, at least for darolutamide and for enzalutamide, that there's a survival advantage for this earlier treatment in the non-metastatic CRPC setting. So there's benefit, although the disease space is inflicted by medical care and may disappear at some point. There does seem to be still benefit to making a choice, just using one of them, whatever works best for the patient based on comorbidity, side effects, and drug-drug interactions.
So you mentioned, there may be some differences with these drugs. All three are clearly beneficial in terms of meeting their efficacy endpoints. All have had published, good patient-reported outcomes data, really showing overall very positive tolerability. But yet there's some nuanced differences. And you mentioned a little bit about, falls and fractures. And so William, what are your thoughts about, we talked about cardio-oncology. What are you thinking about neuro-oncology?
Well, it's a very interesting topic, and Alicia has a prospective study that is moving forward in this area. I think we underappreciate how much damage we're doing to our patients, partly because sometimes it's hard to measure these effects. We know that when we put patients on ADT, they do complain about tiredness, and they can't remember where they put their keys, and things that we may not appreciate might be interfering with their lives. But the vast majority of them go on with their lives. But there's a small subset that we've seen, even with primary ADT, that are really affected cognitively and from a neurological perspective, both their brain, but also maybe their muscles and their overall body functioning in terms of strength. And I don't think we really have fully understood why some patients, whether it's 5 or 10%, have more than expected side effects in that way. And so when you're now adding to asymptomatic patients on top of ADT, you're adding drugs like enzalutamide, apalutamide, or darolutamide, and you're committing them, by the way, to years of therapy. So we can't forget that they're exposed to years of additional therapy. that it's going to affect some of them in a more outsized way. And that's why, even though the quality of life data with these studies has looked actually pretty good, and we have to remember that there's going to be some subsets of patients who are going to suffer more. And I think it's very incumbent on the clinicians to really pay attention to this, because now that we have 3 options, we could consider switching. I do this all the time in my practice because some patients, for example, may be falling on a drug like enzalutamide. I remember I'm in New York City, and my patient comes in once. He's been on enzalutamide for a few months, and he said he tripped 3 times. He had a big bruise on his face, and he didn't attribute it at all to the ADT or the enzalutamide that I had him on. I had to really pull it out of him because he happened to have a bruise that day. And even though the rate of that side effect is probably not more than a few %, when it happens, we know it can be very profound. So I think it's just very, very important to try to balance these, and maybe the side effect profile, as was just outlined by Alicia a minute ago, is something that we should be paying more attention to for our patients.
So just to follow back up on that, so you're switching while they're nmCRPC. Will you ever dose reduce, dose interrupt, and then how do you work that from a practical standpoint?
I've done both. Certainly when I had fewer choices, the first thing I would do is stop the therapy and then re-challenge at a lower dose. Now I have switched some patients, because even sometimes with dose reductions, they may still have some of those same side effects. And I think that darolutamide has been an interesting drug. As we all know, there's no cross-study comparisons yet. All we have is a placebo in each of the studies, and the one study that seemed to have a very favorable comparator to placebo in terms of side effects seems to be darolutamide. And if it is because it doesn't cross the blood-brain barrier, then that would be very interesting and intriguing for me as a clinician and for my patients.